Let me just begin by introducing some who you haven't met yet. Ariel Frisenko, very nice to see you here, past coordinator and national directorate member of Foro Salud in Peru. Wonderful to have you here. You've heard already, indirectly, because his name is on many of the papers, Professor Rifat Otun, who's director of the Global Health Systems Cluster at the Harvard School of Public Health, later of Imperial College London. Amanda Glassman, we're delighted to have you here with us, Amanda, Director of Global Health Policy and a Senior Fellow at the Center for Global Development. And then you've already been introduced today to James Fitzgerald, who is an adopted member of the Latin American region from Ireland, who is Director of Health Systems and Services at PowerHope. So let's start off with trying to draw some lessons from this evidence. And I'm going to start, if I may, with Rifat, because your name is liberally sprinkled over these papers. And Carissa mentioned this, at the 53rd Directing Council meeting at the end of September, beginning of October, a very strong statement was put out calling for collective action across the region to achieve universal health coverage. So a very clear political commitment. Now, we've got the evidence in this series. So what lessons do you take from surveying the evidence around the quest for universal health coverage that can help deliver that political commitment to accelerate action on UHC? How does the science connect with the politics?
Thank you, Richard. I think before answering that question, one should take a step back and look at the context in Latin America, which really has helped to shape the health system reforms and the journey to universal health coverage. I mean, Latin America is incredibly diverse in social and economic terms as well as political terms. A diversity, a rainbow of diversity with a black hole. And that black hole is the social inequalities and the disparities. Disparities in many countries that have had their roots in democratic deficits. So this is what helped shape the response in the context of Latin America, not least in other countries that try to cope with the epidemiological transition. So while Costa Rica and Mexico had democracies in the early 20th century, most of Latin America has been characterized by tumultuous episodes of revolutions, counter-revolutions, military dictatorships. So it was the social movements led by civil society that shaped the reforms, that had its heart the principles of equity, social inclusion, diversity, as well as what in Brazilian context is called participation. So I think that's the first very important lesson that we can draw from, the inclusion of social movements and civil society to help shape health system reforms that meet the needs of the citizens. The second important lesson is the approach Latin America took in this journey to universal health coverage. And early on, the emphasis was not just on universal health coverage, it was universal access. Having coverage is the beginning. It doesn't mean healthcare services. It's the access that really matters. Access, especially those population groups that have not been able to access healthcare services. So that was achieved through a combination of demand and supply side interventions. On the demand side, for example, conditional cash transfers, but also actions to address social determinants of health, which is an important characteristic. And on the supply side, I think what was quite remarkable in Latin American experience was the strong platform that primary healthcare provided. Primary healthcare that was inspired by the Alma-Ata Declaration. A truly community-based approach that also tried to integrate public health interventions. A very important lesson combining both demand and supply side interventions. And the third important lesson, perhaps one which has not emerged as strongly as it should, is the learning from Latin America, both at country level but also cross-country and regional learning, that helped to shape South-South deliberations in health system reforms, to provide this solidarity that you talked about. So it wasn't just solidarity at country level. It was solidarity at country level to shape health system reforms, but also provide lessons to the rest of the world that's moving towards universal health coverage. And the recent declaration, the recent resolution, CD53R14, I believe, from the Directing Council, is further evidence that Latin America and PAHO is playing a leadership role. Because this resolution takes universal health coverage to a new level. Because the resolution states not just universal health coverage, but universal access to health. And that is the critically important lesson and an important learning from Latin America. And I'm delighted to see Dr. Carissa Etienne as the director of PAHO pushing the frontiers of universal health coverage to new levels.
Very good. Thank you, Rafet. Now, Amanda, you occupy a very interesting position here. You've had at least 20 years of your career working in the Latin American region at various levels and across various sectors. But you also have a broad global role as well, an interest. So I'm very interested to know, what are the lessons of the experience in Latin America and its quest for universal health coverage for other countries that are going through similar questioning about how to get to that social goal? What's the connection between Latin America and the rest of the world?
Well, I think a really important issue has to do with the pooling that the public sector did, with the focus on reaching the poor first, and a lot of that actually was born from the financial crisis of the 90s. It was in a way an opportunity to focus more on groups that had never had a safety net, and I think that also played out in the health sector, which is great. I think another lesson from Latin America has to do with the emphasis on financial protection right from the start. That was always an issue, out-of-pocket spending, and the reforms of the 80s and 90s were focused on that as well. The rest of the world, I think, arrived later to that issue. And I also have to appreciate the great impact evaluations of the insurance and coverage schemes that Latin American countries have done. You think of the SUS in Brazil, the Colombian Social Security reform, and I wished so much that Colombia had been part of the article that compared health systems. The Mexican reforms, that was published in the Lancet. There are others. And it's just a great body of evidence that I think the rest of the world can learn from.
No, that's great. So let me just move to James then now. James, I mean, under the leadership of Dr. Etienne, PAHO is one region of WHO that really has put universal health coverage at the absolute top of its priorities. And I think we don't only admire that, we really feel that that's a courageous decision to make for a region. Now, what do you see as the lessons of this bringing together our knowledge that could be helpful for PAHO? You've got this political commitment, you're in the driving seat in leading the region here. What can we take from the science and the policy analysis into concrete actions, do you think?
So, I mean, when the ministers adopted the resolution 2 weeks ago, I think you could feel the excitement in this room, the applause and the enthusiasm really to move forward with the implementation phase. And that's really, I think, where this paper links in now with our work moving forward. In the resolution, we have 4 clear lines, strategic lines of action. One, the first, to really accelerate access to comprehensive integrated services to meet unmet needs. And the second, to strengthen stewardship governance. The third, more and better financing. And the fourth, social determinants of health. All these lines are completely articulate with the 4 papers that are presented here within the Lancet publication. I think where the resolution perhaps goes beyond is what you said in terms of access. It really firmly links the principles, the right to the highest sustainable standard in health, the values, the social values of equity and solidarity with the principle of access, and then with coverage. As you know, there was some discussion within the region on what coverage is, and we had a very principle-based discussion here within the organization. And that allows us now to move forward with national roadmaps, working with the countries on what was mentioned by Tim earlier on, to link universal access and universal health coverage with initiatives that have been a long tradition of this organization in monitoring essential public health functions. And we believe that this is the way forward.
Oh, that's fantastic. But Ariel, you've written a beautiful comment with Alicia Yamin in the issue on human rights-based approaches to health in Latin America. And I want to just explore that a little critically if I can. I was at I think it was a spring or fall meeting of the World Bank a couple of years ago, and I was riding in the back of a taxi. I won't say who it was with, but it was with a senior person within WHO. A very senior person in WHO, and she said, oh, I've given it away. She said, Richard, whatever you do, don't mention health as an entitlement or as a human right. Now, she wasn't saying that because she didn't believe it. She did believe it very strongly. But her argument was, if you go into meetings with ministers of finance or heads of state and start talking about health as a right or as an entitlement, they switch off. And you cannot win the argument with a rights-based approach. Now, I don't know whether she's right or whether she's wrong. Is she right or is she wrong?
Sometimes Richard could be right, because sometimes when we have spoken about her rights to some collectives, we have found like if we were like these religious people that knock your door and you don't want to listen to them. But I think if we are now speaking about people-centered health systems, if we are talking about universal health coverage in its integral dimension and not in some capture of concept like making a synonym of universal health coverage as a universal health insurance alone, we need to consider that right-based approaches, as we try to make the position with Alicia in the comment, are contributing to universal health coverage. Absolutely, because it contributes with the underlying social determinants. So it says to those who are implementing universal health coverage, okay, what's the indicator for social determinants? Are we going to try to achieve universal access for safe drinking water? That should be in the framework for universal health coverage. Are we going to reduce violence against women? That should be, no? But mostly, right-based approaches contribute with some dimension that sometimes is neglected in the countries, which is accountability and citizen participation. Could we talk about people-centered systems without listening to the people? Which is the indicator of governance for universal health coverage. Because if not, I think we are just misleading and losing the opportunity. So I won't maybe stay stuck in the titles, but titles are important because there are legal obligations signed by the countries on human rights. I will try to disaggregate and operationalize those human rights and principles as we try to do at the comment. And in 2008, the Lancet made a launching of a very unique piece analyzing how health systems were implementing their actions and analyzing that through a right-based approaches lenses. It's 6 years already from that. I think we should make an effort to see effectively, again, maybe with better improved indicators, how much health systems in Latin America are effectively implementing a right-based approach in their interventions. And we're going to have surprises, and we're going to learn. And I think the best political recommendation would be place Janet's Action 10 in the first place. Because always citizen participation and accountability is just given to the last places, and sometimes nothing is made. Let's put the last in the first. And I'm also talking about the people.
Very good, Aaron. I'm going to come to the audience in a minute, but what I want to do is ask each of you the same question now. And I'm going to start off with Rifat, so give everybody else a chance to think about this. I'm starting with you because in the first paper of the series, Rifat, you identify 5 challenges facing universal health coverage in the region. I want you to single out what you think is the biggest threat. We've had a really optimistic vision set out by every speaker. And the series is overwhelmingly optimistic about what can be achieved. But I just want us now, not to be negative, but just to be realistic about what you see as the biggest threat facing our optimistic objective. And I'm just going to go in the same order to start with you.
Excellent question, a multi-billion-dollar question, I should add. Again, context is important because, as we've heard, in the context of Latin America, beyond Costa Rica, Colombia, and Mexico, where the reforms were driven, a measured response to the epidemiological transition. In most of the other countries, the response was very much driven by the democratic deficit. And this urge to attain citizens' rights, and health was part of those rights. And in many countries, there have been a journey towards progressive universalism, to coin the term coined by the Global Health 2035, to achieve certain rights, and rights in relation to health and health protection. Now that we have these rights, and that has been partly helped by the economic growth, which in the beginning was an impetus for reform, but then help countries to introduce universal health coverage and universal access. Now that we have these rights, the key challenge is going to be sustaining universal health coverage and universal health access in an equitable way, because the citizens have been awakened and they're holding governments accountable. So how are we going to sustain the gains and continue the trajectory that we've been able to achieve? That's going to require governments to make some very hard choices, where to invest. But of course, there's no better area to invest than health.
Fantastic. Good. Amanda.
So I agree with you. The flip side of high growth is that there's been an enormous pent-up demand and utilization of health services. There's a lot of access to new technologies and pressure to adopt new technologies that may or may not be cost effective. There are increasing numbers of legal cases. Tim mentioned the judicialization issues, and Elise worked so much on that. So that taken together in a weak institutional context means that it's tough to set priorities that favor public health. Right. And many countries lack evidence-based, ethical, transparent processes to set priorities. There are exceptions. There's Anvisa, which is a great inspiration in Brazil. There's some new efforts in Mexico. Colombia just set up a health technology assessment agency. But too often, that institutionalization is missing. And then the other issue is, even if I have a wonderful prioritization up at the top in a list, I should mention Auge as I'm looking at Jeanette. But when you decentralize funding and responsibility to subnational entities, which is the case in the big federal countries in Latin America, sometimes that prioritization does not go with the money. And therefore, local entities are making all kinds of decisions, some of which are good and some not so good. So I think that's a big challenge as well. And can I just throw in a last thing?
Please.
That Dr. Carissa talked about human resources for health as being at the center of universal health coverage. But say in Peru, we've had just 150 days of medical strike finish. What does it mean if human resources for health are really not working necessarily for health? Or if they have multiple, let's say, incentives that are not necessarily compatible with this vision of UHC? And how are we helping ministries and insurance agencies to cope with that problem?
Thank you very much. James, the biggest threat to PAHO?
To PAHO? Wow.
Geneva. No, go on.
No, I would say that probably the biggest challenge, perhaps not threat, but challenge that we have moving forward is translating the political will, this movement, into action in the countries. Yeah. I think this is really now where it has to happen. I think we recognize that there has been an enormous global movement on issues on universal access and universal health coverage within the United Nations General Assembly, within WHO, within this region here with our strategy. And now we have to really translate that and make sure that the ministers of health, jointly with ministers of finance, ministers responsible for social development, come together and really work collectively on national processes, plans and strategies to make it a reality. And we have to also be very aware that our window of opportunity normally is quite limited on these things, that the global agenda in health evolves. And it evolves very quickly. We can see that now with Ebola. But we have to avail of this window of opportunity so that the partners that are committed to really working with member states in the national planning processes, in the reform processes, remain there and remain focused to make universal access and universal health coverage a reality.
Thank you very much, James. Biggest threat, Ariel?
I think one of the biggest threats is learn to listen. Learn to listen. We need to overcome somehow this kind of technical autism that sometimes we fail in, you know? And together we learn to listen. I think the quality dimension is very important. We have been running behind metrics of deaths with the Millennium Development Goals. And sometimes even for building the social action, we have found challenges in Latin America because now we are improved economy in most of the countries. So donors are leaving, and those who have not left, they are not so interested in social processes, how governance processes are, because they are complex, they don't have predictable results, they don't reduce directly maternal deaths. So we need to make a bet for governance. We need to make a bet for real democratic health systems. I think that's one of the biggest challenges. So that's not only political will, it's learning how to build together those democratic health systems. And we need to think that things are possible if we have the commitment. In 1994, when the first so-called public insurance systems were set in Bolivia, for example, in the Seguro de Maternidad y Niñez, many technical colleagues, some of them close colleagues from the World Bank, say that that was useless because it was money to be lost. Poor were going always to get sick, and they're going to cost to the health system. Today, in most of those countries, the so-called public insurance systems are part of a key tool to get the universal health coverage. So things could change. Whenever we say that we are aspirating to have a unique benefits plan for all the population, with not the segregation that sometimes insurance systems establish based on the economic power, we really think that could be achievable. And maybe you will say I'm speaking nuts, as in 1994, other people were saying that those systems were useless. Okay. 2 years ago in Beijing, I was very inspired for a brilliant speaker who said that we need to be visionary and we need to be radical. I think we need to be radical and visionary and think beyond our own mental barriers.
Very good, very good. Now, let me come to the audience, but before I do so, I need to have a signal from somebody about how long I'm allowed to go on beyond the stopping time of 1 o'clock, which is when we're supposed to finish. Somebody give me a number for how many minutes I can go beyond 1. 5, 10?
5, 10 minutes.
Okay, great. So let me come to the audience, and please put your hand up, wave at me, and say who you are and where you're from, please. And press whatever you need to press.
Alicia Yam and I co-authored the comment with Ariel on rights-based approaches. I just wanted to make a comment since the theme of judicialization has come up throughout the panels, and to say I think there may be some misconceptions. First of all, the conquest of rights and the right to health in the region, I would say, is quite incomplete and in process. And judicialization, the overuse and sometimes abuse of judicialization, is a symptom of it not being complete, is a symptom of failures in the system as opposed to the problem itself. I think we have to make a distinction between quality skimping, that is, things that are supposed to be guaranteed in these universal health coverage schemes, which actually people cannot get access to. And that's generally in Brazil and Colombia about 2/3, 70% of the cases. And then what courts give beyond those coverage schemes, which can be driven by pharmaceutical companies bringing litigation, which can be not evidence-based, et cetera. And I was glad to hear Amanda talk about how people turn to the courts precisely because of a lack of legitimacy in the priority setting processes, a lack of participation, as Ariel said, and a lack of accountability on the part of the political branches of government for actually delivering on their promises for what they say they will.
Very good.
Thanks.
Thank you very much. Neil, I think you were going to make a point too.
Sí, muchas gracias. Soy la representante de la Asociación Latinoamericana de Medicina Social Primero, me parece una decisión muy importante que la sesión de la OPS hubiera incorporado, hubiera comprendido que incorporar el tema del acceso universal, felizmente, porque hablar de cobertura era totalmente insuficiente y es una de las partes que nosotros hemos estado debatiendo. Sin embargo, es también importante ubicar que una cosa es el acceso a los servicios y otra cosa es el acceso a la salud. Y por ello mismo me parece importante que el OPS en su estrategia no confunda esto, porque nuevamente se ve ingresar el riesgo que se ingrese nuevamente a medicalizar el problema de la salud cuando la salud es un derecho colectivo y por tanto hace a la estructura del Estado. Las determinantes forman parte de la estructura del Estado y forma parte del tipo de estrategias de desarrollo que tenga el país. Y acá yo quiero agarrar varios temas en realidad, y uno de estos es dentro de las determinantes sociales, además de agua, etcétera, etcétera, está un tema que cada vez es más fuerte y es el medio ambiente. Y el medio ambiente hoy nos está llevando a no solamente aumentar una serie de patologías, sino está llevando a destruir terrenos, territorios, etcétera, en función de X formas de producción de alimentos para, qué sé yo, para bioenergéticos, cuando la gente está cada vez con más problemas de alimentación. Entonces, no solamente de la alimentación del día, sino que los alimentos que está incorporando son alimentos contaminados y por tanto nos está llevando a un desastre universal, ¿no es verdad? Entonces yo quisiera, por una parte, ubicar que las estrategias que define la OPS y los países y todos nosotros es ver el tema de las determinantes, no solamente en función de si existe 100% de agua, bien hecho, sino es qué tipo de calidad de vida se está llevando adelante y lo que significa la lógica de la destrucción del medio ambiente. Dos elementos más, bien rapiditos. Cuando hablamos de acceso universal, estamos hablando de resolver los problemas de obstáculos para también llegar a los servicios. Y dentro de los obstáculos, yo ubico como 6 obstáculos grandes, pero hay 2 importantes. Uno es el tema de las culturas, y por ello es que en Bolivia nosotros trabajamos mucho el tema de la interculturalidad, no solamente en Bolivia, sino en todos los países, no como incorporar el tema de la interculturalidad a partir de ubicar que los indígenas tengan una cultura y hay que hablar en su idioma. No ese es el tema de la interculturalidad, sino que es el respeto a las formas de pensar y de construir la vida. Y este tema está muy ligado a lo que es la formación de los recursos humanos. ¿Cuál es la actitud del recurso humano? En ninguna parte yo he visto que esté incorporada un debate sobre la función de las universidades. Las universidades son los formadores de recursos humanos. Y si la universidad sigue formando profesionales para los hospitales, no estamos resolviendo el tema de la salud. Entonces yo reduzco, es muy poco el tiempo, yo agradezco ubicar y recomendar el tema de las determinantes, pero en este contexto amplio, el tema del equipo médico, el equipo de salud, no solo en su calidad técnica, sino en su actitud, ¿no es cierto?, de comprender, y el tema de comprender que la salud es un derecho social y por tanto es un respeto cultural, ¿no? Gracias.
Thank you very much indeed. And I do encourage you to read the paper that's included as a separate item with the booklet from Neil Heredia and her colleagues, and it will be printed in the Lancet. It just was a little bit delayed to get to the printing for the booklet. I'm just looking in the center and on my right here. Yes, please.
Thanks very much. I'm Kate Bond with the U.S. Food and Drug Administration and want to thank all of you for a tremendous set of presentations. I think one area that has been perhaps less explicit in the discussion of universal health coverage and relates to item 3.8 that Dr. Evans pointed out is access to safe, effective, quality, and affordable medical products and vaccines. And the regulatory function here to oversee safety and quality can easily be argued as one of those essential public health functions that Tim Evans referred to. I think one of the things, as Mike Myers pointed out, is the PAHO region has been asserting a great deal of leadership in both attention to strengthening regulatory systems, but also in creating the kind of solidarity and collaboration within the region that embodies many of the principles of UHC. Dr. Etienne has also been extremely effective in bridging the UHC context to drug regulatory authorities, as we all experienced in Brazil at an International Conference of Drug Regulatory Authorities recently. So my question really to James, given the leadership of you and your team in PAHO, is what more, given the momentum and movement around regulatory system strengthening and the focus going forward in implementing UHC, what opportunities do you see in terms of bridging these? And more specifically, are there any other areas of research or even going further to define and develop measures, metrics, targets that could help move this part of the agenda along? Thank you very much.
Very good. And now I'm looking over to my right. Any questions from this part of the room? No? Okay. Anybody got a burning question? Okay, please, sir.
Thank you very much. Richard Van West Charles, former PAHO WHO employee. Let me congratulate you on what has gone on so far. It's a continuum even from, I think, the 80s and before. But I think what is important to my mind is placing the UHC within the context of development in a clear way. I think I was a former minister, and one of the challenges that you have at a governmental level is that ministers of health or health professionals do not have the necessary tools to influence the investment to achieve UHC. And I remember in the 80s, the Commonwealth Secretariat had a meeting with health ministers and ministers of finance looking at this issue. And the empowerment, I think this has to be placed within the context of a developmental agenda, and not necessarily, to my mind, residing within the ministries of health, but outside of the ministries of health, especially as we talk about the intersectoral action and how we can do the analysis. And I think this is from the perspective of health professionals now, that we have to be able to take the epidemiological data, information, and knowledge and disaggregate it into an intersectoral way that would say to governments, these are rigorous tools that we have, that if we have an epidemiological situation within a certain geographical community, the investment needed to achieve UHC, because people are central to the developmental process, is required in this way. Without those tools, it is left to the individual persuasion of a minister, how high he or she is within the cabinet. And therefore, I think we need to develop the tools that would guide the investment and the allocative efficiency to achieve UHC. The other issue is the multilateral agencies and the bilateral agencies. We all need to have very similar indicators by which will guide the UHC and its investment, because invariably, too often, we see a disparate sort of investment from the multilateral and bilateral agencies running amok. And to James's point, how do we guide that investment at a country level? So that becomes important to me in terms of some of the research, further research that we need to do. And how are the indicators of UHC linked, for example, to the Human Development Index at a country level? So I think those are some of the things, to my mind, that we still have to do to assist governments. And in this forum, we're talking to the converted. Okay. And I think there needs to be additional work, which I call the health literacy of the political directorate, because governments change.
Okay, very good. Now, time is disappearing, and it's very sad, but it is. So I'm going to come back to our panel. You've got one final comment. I don't want you to leave the panel without feeling you haven't had the chance to say the one thing that's burning on your mind, but you've only got 30 seconds. So we're going to start with Rifat.
I agree strongly regarding seeing health as an area to invest in. And health has some of the best returns one can have, especially given the bond yields now that are going into negative territory. In terms of the returns on investment, health is the place to invest in. It must be part of the development. Not that it must be, it must lead to development. We have very strong evidence that health does lead to improved societal, beyond the intrinsic value of health, societal well-being, as well as economic growth and wealth. So we need to stress this, but have the evidence base. Beyond the normative arguments, we need to have the positive arguments that show that investing in health will lead to improve health outcomes, but also improve economy to benefit the all.
Very good. Final comment, Amanda.
Well, just to add to that, I think we don't often value health infrastructure as productive infrastructure. When I used to work at the Inter-American Development Bank, I was always arguing that I was part of the productive sectors, and they were like, yeah. So making that real-time argument to ministers of finance, I think is really important. And the second part of that is really understanding what the long-term fiscal liabilities are of our decisions today about what is covered and not covered. Given that the population is aging, there's a high prevalence of risk factors, there are enormous inequalities and pent-up demand. So being clear about what the fiscal requirement is, what health it would gain, what economic benefit we would get us a long way.
Very good. Final comment, James.
I suppose my final comment would be carpe diem, seize the moment. We have a regional, very strong mandate that speaks to many of the issues that Neela has highlighted here, that goes beyond universal health coverage and reaches out to the concept of universal access. And I think that's something we need to build on. To respond to Kate, we have lessons to learn from in other areas of work. Quality and access are central to the concept of universal health coverage, are essential to the concept of regulatory functions and systems. And I think that's probably where the bridge can be. If we potentially move away from the normative focus and move into the functional approach around quality and access, I think we can really move this agenda forward.
Thank you. Ariel, final comment.
Yeah, I agree that's a governmental issue and we need to fight for that. And probably our best allies are those neglected civil society organizations that could influence decisions, especially in electoral processes. And the last comment is about sustainability and legitimacy. I'm talking about democratic health systems. I can't conceive that already now how we are, we're still just considering democracy voting each 5 years. We need dialogue spaces, and those local dialogue spaces will be the better places to inform what is exactly happening with these great ideas that we try to achieve from the central level. So that will be my two last comments. And I also welcome the resolution of the Pan-American Health Organization because it's universal access to quality, timely health services.
Very
and
good.
Beyond health services.
Very good, very good. Please give a round of applause for our panel.
Thank you.
So it is now my great pleasure, having thanked the panel, to invite Dr. Carissa Etienne to close proceedings today. We're a bit pushed and you don't want to hear from me anymore, so we're going to hear from Dr. Etienne, who will have final remarks. Carissa. Oh, would you like to speak?
Uno.
There you go. There you go.
Well, you can't beat my team in power, ever. No, Richard, the supporters of this, the co-sponsors, the authors, all of the persons who came here, the invited guests, and our staff. This is an agenda of high importance for this region. It was evident. How many times do you see ambassadors would come here and sit and for the launching of a series? It is because it is at the heart of the political will of this organization. And as a director of PAHO, I think what is my biggest worry is how at a global and regional level, how do we transform this agenda not merely as a health agenda, but as a global and regional agenda, but also an agenda that has national significance. So it is beyond health, and this is where we need to take it. And that's why I think that people like Richard, you are very important, all of our partners here are very important, because we need to change the discourse. As long as we continue to talk about health financing and insurance, etc., you will have lost many of the people of this region. We have to engage, particularly the World Bank, that we begin to see it in a holistic manner. And the World Bank is very important because we need to get to the ministers of finance, and they are an interlocutor. So this is, for me, the biggest challenge. The biggest challenge where we can begin to see that there is no development if people are not at the center of development, and there is no development if your people are not healthy and if they do not live dignified and productive lives. And so that is our challenge. So I really want to thank Richard for this opportunity. I know it was a lot of hard work. I attended 1 or 2 meetings, and I was happy that I could leave. But it took a certain level of tenacity and certainly perseverance to get us to where we are today, a series that we can be quite proud of. Proud of the work that brought it here, but also proud of what countries have done in terms of the history of the health development in Latin America and the Caribbean. So I won't stand between you and lunch. So I want to thank everybody who was involved. It's good to see some friends and to renew acquaintances and to see each one of us has a role to play. We need to be able to engage civil society, the people, because lots of the time people say, well, I don't know about civil society, or they don't represent me. We have to be able to engage people broadly, civil society. We have to be able to engage all of the sectors. Everyone must see that this is an important agenda for me, for my family, and for my society. So thank you so much. Onwards we go, because we know that we must not fail. And if we go with this, we must not fail. We will arrive at the day when we can say that not only in Latin America and the Caribbean, but certainly all over and across the globe, that people, it's accepted that you have access to health. It's accepted that you are given all of the environment and other factors that allows you to live a healthy, productive, dignified life. Thank you that you are partners on the journey. Thanks.